Good evening and welcome everyone to our first Fellows Corner webinar event. Tonight's presenter is Dr. Tyler Kemnic. He sits on the Education and Program Committee here at the SAB. We do encourage questions throughout tonight's presentation. We are able to discuss them after. Feel free to submit them by using your question feature, which is located on your control panel. You also may raise your hand and we can grant you audio access. Dr. SAB Education will be our moderator for tonight's session. He also is a part of the SAB's Education and Program Committee. So I'll hand it off to him and he will get us started.
Thank you, Emily. I want to welcome everyone who is joining tonight. And we have our first Fellows Corner webinar, and I want to welcome everyone tonight. So Tyler Kemnic is a pulmonary critical care fellow doing the fellowship. He's a second-year fellow in Michigan State University. I would like to welcome Tyler, and we're going to talk about the rare case of central airway obstruction. I'm going to hand it to you, Taylor, and we can start presentation. So at the end, we're going to encourage everyone, if they have any question, they can raise their hand, they can type in the chat box, and we'll discuss, and we can address all the questions. Thank you.
Awesome. Thank you guys for the introduction. So yeah, we're going to talk about a case that I had a couple months ago while rotating on pulmonary that I thought was pretty exciting. Let me transition here. Some objectives for us today is to define central airway obstruction, a CAO, to discuss the incidence of ectopic intratracheal thyroid tissue, and then to define the management of the ectopic intratracheal thyroid tissue, including post-procedural treatment. A little bit of introduction. A central airway obstruction is defined as a blockage of the trachea or main stem bronchi. This can be broken down into 3 different subgroups, and we can see them on the images to our right. We have intrinsic, which is our furthest right image, extrinsic, which is going to be our top image, and then more of a mix where it's intrinsic and extrinsic in regards to the luminal wall of the trachea for the 3 definitions. Our case is a 25-year-old female that presented to pulmonary following with her primary care physician since age 17 for asthma. She had been reporting shortness of breath with exertion and lying down that had been worsening, especially when she was in bed. At the time of consultation, she was being treated with inhaled corticosteroids and a long-acting beta-agonist and a short-acting beta-agonist. She admitted to wheezing and a productive cough with clear phlegm. She also reported nicotine vape use occasionally, and her exam was significant for audible stridor, especially during inspiration. However, she didn't have any wheezes on exam. This was something that we were able to find later, probably 4 days after the case happened. We have a PFT that she completed at an outside hospital that we had uploaded. And even at that time, so in 2017, about 5 years before her presentation, she had a fixed obstruction on her PFT that was never really addressed. Our in-office pulmonologist got a pulmonary function test that day in order to stat CT of the neck and thorax that the patient completed after leaving her visit. And after the CT imaging was completed, the pulmonologist called the patient back and asked her to present to the emergency department emergently. This was our PFT that the patient completed in an office, and as you can see, both the inspiratory and expiratory loops are severely obstructed in a fixed pattern. CT imaging, we have a few axial as well as sagittal and coronal views of what was seen in the trachea. Right above the glottis, you can see an obstructing mass about 95%. It measured 1.5 by 1 by 1.9 centimeters. At this point, interventional pulmonary was consulted for evaluation of the patient, and it was decided to discuss the case with anesthesia and undergo rigid bronchoscopy with tumor debulking. The tumor debulking we decided to do with a snare technique, and using argon plasma around the snare was able to heat the stalk of the tumor and pull out about 90% just in that one pull, and then trapped it. Once that was taken out, we switched over using to ND YAG laser and the laser therapy helped us clean up the area to about 95% opening of the trachea. The tumor was found to be between the first and third tracheal rings. And here is our pre and post photos. So the pre photo on the left is when the rigid bronch was introduced past the glottic area, and you can see the mass pressing all the way into the anterior trachea. And then our post intervention is with our flexible bronchoscopy once we were cleaning up. Our pathology report, ectopic intratracheal tissue, EITT, involved margin, benign condition that is rare but well described in medical literature. So the patient was discharged home only 1 day after the procedure. She had some cough and she had a change in her voice for about a day, but with some lozenges, she had much improvement. She followed up with our lung mass clinic and was discussed at tumor board, and the decision was to continue with surveillance of doing PFTs and a follow-up CAT scan. We also consulted endocrinology, who we wanted to discuss doing any thyroid suppression with hormonal treatment, and they decided that it wasn't necessary. So ectopic thyroid tissue is rare, and the occurrence in the laryngotracheal region is even more uncommon. Due to its low incidence, ectopic intratracheal thyroid tissue is often mistaken for asthma, as was in our patient. EITT may not be diagnosed until a catastrophic upper airway obstruction has developed, which fortunately our patient was symptomatic with audible stridor. However, she wasn't requiring any oxygen. It was a lot of discomfort. There are less than 500 reported cases of EITT in the literature, and the two postulated causes are the malformation theory, which is the tissue grows incorrectly and then enters the trachea and comes over time, which may have happened with our patient. We have that earlier PFT where it was already starting in 2017 and then the worsening. And then we also have the ingrowth theory where in development it's occurring and then it's happening at a younger age. So management of the EITT is determined by the degree of obstruction and size of the lesion, as well as the patient's age, thyroid function, which was normal in our patient, and the histological findings. Most patients do not develop symptoms until they undergo a change in hormonal status, which our patient was past any large hormonal changes. You'd think it would have happened earlier in her life. Factors that stimulate growth, including TSH, epidermal growth factor, and human chronic gonadotropin. Once symptomatic EITT causes difficulty breathing, cough, stridor, and sometimes dysphagia. The two most common methods of removal are endoscopic laser, like in our case with rigid bronchoscopy, debulking, and laser ablation, and removal of the tumor via open cricoid procedure. When considering definitive management, surgical removal should be considered the best option for long-term outcomes. After thyroid suppression should be considered to prevent further growth or reoccurrence of residual tissue. So conclusion for our case, EITT is a rare and potentially life-threatening central airway obstruction that can be managed by rigid bronchoscopy. After diagnosis, the case should be discussed with endocrine to consider thyroid suppression therapy, and then as well as at a tumor board to discuss further surveillance with imaging and PFTs as needed.
Taylor, thank you. Thank you for interesting case presentation. So I have a couple of kind of questions and about the details of the procedure, and I just want to kind of discuss that with you. So you mentioned that the patient, you started bronchoscopy with the rigid, yes, and what other consideration? I think it was discussed before. Maybe you could start with the LMA, with the flexible kind of bronchoscopy to check the lesion, the severity of obstruction, or the length, or just for airway exam that you know what you're dealing with. So was that considered, or just decided that you're gonna start with the rigid scope?
No, that's a great question. We actually did start with LMA. So we did a little bit of sedation with propofol and then introduced a flexible scope. and we numbed up the vocal cords just to see what we were working with. And then
Okay.
once we saw the severity of the obstruction, we sedated the patient a little bit deeper and introduced the rigid. The patient was very resistant to anesthesia, and even when the rigid scope was introduced, we had trouble keeping her from biting. We really had to use a little bit more, but we wanted to be careful with how much we were giving her because we didn't have a secure airway at the beginning of the procedure.
I see. Okay, so you started with LMA. I think that's a great way to start a case, unless you really it's emergency and you don't really have a time. But I guess most of the time you have a time to kind of do some airway exam, unless it was done before. Sometimes we get the referrals that we are kind of it already was bronch, but again we kind of want to bronch ourselves to see what's going on. The rare cases that you know what you're gonna do, you already know the patient, kind of it's a clear-cut case, you can start there with the rigid. I think that's also an option, but usually the safest option, just start with the like a LMA with airway exam and try to see, try to just pick your modality, which way you want to proceed and what you want to do. And just a bit detail of ventilation. What type of ventilation you use? Is it like a conventional ventilation or jet ventilation during the case?
We were using conventional ventilation during the case, and we had pauses occasionally.
Okay. So other option, I would say, for example, University of Minnesota, we use jet ventilation almost in all cases. So we have like a monsoon is like automatic jet ventilation. It's not manual, but the manual is also option. So the jet ventilation kind of gives you an option having like good like ventilation strategy. But again, there is nothing wrong with the conventional ventilation. And I have one more question about like the follow-up. So you said that the patient is going to follow up. Is there any plan to do any bronchoscopy or just a clinical follow-up or imaging follow-up? What was the discussion before discharge?
So right now for follow-up, she's scheduled with our general pulmonary office to get a PFT. And then at about 4 to 5 months, we're going to be doing a CT of the neck and thorax. There's no plan for repeat bronchoscopy now. It's always something we can consider, but we really want to follow that flow volume loop in the CT to see if it's really needed.
Okay, great. Yeah, I think, again, if you want to be conservative, you can do just a follow-up bronchoscopy, just an airway exam, but clinical follow-up with the PFT, so repeat imaging like a CT scan of the neck and the chest, and that's also kind of option. So, okay, great. So is there anything that in that case that you think could be done differently, or like after doing the case, and would you do anything differently, or you think everything was done like in the right way and you didn't really change, you didn't want to change anything? Let's say related to procedural part of the procedure, like a case.
Well, even before the procedure, I think 2 things. I think perhaps she should have gotten CT earlier, especially her stridor was very significant and she was being seen by people in the outpatient setting. And perhaps maybe she should have been direct admitted from the pulmonary office, though she was admitted the same night as her pulmonary visit, so it wouldn't have changed that significantly. In terms of procedure, I'm wondering if we should have discussed the case with CTS beforehand.
I see. How about like any concern that if you need a like ECMO backup, let's say you do the case and you kind of don't have a secure airway, even with your like you're trying to do rapid debulking or kind of have a patent airway, but was there any like concern that the patient may need like a ECMO backup to kind of buy time till you get the airway?
No, that's another really good question. We actually did discuss if we would need that if we failed at obtaining an airway. We did talk with the on-call CT ICU attending, and we determined that if we were getting to those issues, that we would have the CT ICU come down to the bronch suite and evaluate.
Okay.
Doctor.
Okay, great. I would say my suggestion, like always, we here in Minnesota, we always give, if you have a central airway obstruction, especially tracheal like obstruction that we think that patient may not tolerate, like anesthesia, jet ventilation, lying flat, then especially someone who is very sick and with underlying lung disease or like morbid obesity, let's say, we always kind of give the heads up to the anesthesia and the ECMO team that we may need. And kind of, there were several cases that we had an ECMO backup and patient was cannulated and we didn't use, but there was one case that we actually used the ECMO because patient rapidly deteriorated with the tracheal mass and we couldn't kind of, we didn't even have a time to kind of open the airway even with the rigid coring, I would say. It was a little bit difficult case. Great, and one like a tricky question. Of course, this is not for you. You are a pump critical care fellow. You are not interventionalist, and but let's say you are doing like a case and you're just with your rigid. You enter and you are trying to kind of debulk with your tools, like as you mentioned, snare or APC, and or mechanical or cryo debulking. Then you kind of losing the airway and patient desaturates. What you could do, let's say as a kind of last resort thing for emergency, and you don't have a ECMO backup in this type of cases. What do you think? What would be your action in that time?
So are you suggesting to advance the rigid scope and use it kind of as a knife as itself and then to intubate further?
Yes, that's one of the options. Yes, that I had that in mind. Again, you want to do everything nice and clean and in the secure settings. Try to like make sure it's not bleeding, coagulate, then debulk. But sometimes you don't have a good view. Patient is desaturating. Anesthesia is kind of saying, you know what, SATs are like going down, and you don't have time. If you know your anatomy, you know the lesion where it's located, you can kind of do rigid coring with your rigid bronchoscopy, advance and kind of try to reach to the carina and have a like an airway, and with the hope that your rigid scope is going to tamponate whatever bleeding is there. At least you're going to have an airway. Of course, that kind of last resort thing. Sometimes it's the first. If you really, sometimes you can do a rigid coring from beginning. That's intentional coring, but sometimes you need to do as a. There's no other options. You just need to kind of have an airway. That's one option. Okay. And the other thing I would suggest, we did several times. You can hook up the rigid suction catheter to the oxygen. The rigid suction, and you hook up with 2-3 liters oxygen or more than that, and you can pass through that narrow stenotic area distal to the obstruction and kind of ventilate with that. Again, that's a temporary thing, that's a last resort thing, but it can be done too. So you can kind of tell you kind of the airway.
Yeah, I think that's a great idea, Dr. Shishin. I think that, you know, whenever you do rigid debulking, you have to be really careful about your planes, because especially if you're in an emergency, you want to make sure your planes are right so you're not entering the mediastinum or damaging any structures within the airway. But I think the idea of placing a catheter distal to the obstruction and oxygenating distally is actually a great idea. I did have a good question for Dr. Kemnic. I thought it was an excellent talk, Dr. Kemnic. One question was, what was your positioning of the patient when you guys initially proceeded with anesthesia or airway evaluation of the patient? Did you have them completely supine? Like, what positioning were you?
She was completely supine in the sniffing position for the entire procedure.
Okay. Sometimes what we have done is maybe have them somewhat more recumbent, you know, as this is you know, classically in the setting of airway obstruction, you may even hear about patients getting to be sitting almost nearly completely sitting up. as you intubate them, just so that you can have control of the airway, and if there are any medications are giving, you don't lose the complete airway muscle tone and don't have any obstruction. So that's something I think people can also try, just having the patient being a little bit more recumbent or even sitting up. What are your thoughts about that, Dr. Kashishna?
Yeah, I think that can help, but it depends on the case. I think you can try different like strategies, and the most difficult patients whatever I saw during I'm doing interventional pulmonary fellowship, by the way. So the obese patients, yes, I think that's one thing that you wanna. Sometimes you even just put that like reverse Trendelenburg position sometimes, because you, especially with jet ventilation, sometimes you need to kind of adjust your ventilation settings to have a good tidal volumes and chest rise.
I think it's very important to have good anesthesia support. Obviously, if you have monsoon ventilator, then it makes things a lot easier. However, if you have anesthesia and you're using the older jet ventilation technique, then you really need to make sure you have good communication with the anesthesia about the frequency of the jet and what pressures we are going to be trying to obtain for the patient in order to actually to have them patients safely tolerate rigid bronchoscopy. So I think the discussion between anesthesia and the interventional pulmonologist becomes very important, just like in every interventional case. One other comment that I had was, we have had cases where we have not completely cannulated the patient when we've been worried about impending central airway collapse, and we have discussed the case with CT surgery, CT ICU, and we have actually just placed wires into the vascular space. So if the patient needs to be cannulated, they can be cannulated, but if that is not required, then the patient does not have to go through the process of being decannulated and everything that comes along with it. Obviously, that makes the case a little bit longer, but something that we have tried in the past, to just have wires within the vessel, in the vascular space, so that ECMO initiation is somewhat quicker than would be otherwise.
Yeah, I agree. So that is just quick question. I don't know your experience. Let's say this case that Dr. Kemnic is presenting. Let's say you do the rigid bronchoscopy and kind of you are not sure that you're gonna achieve the good patency of the airway with your debulking. Would you consider kind of temporary stenting when you have a window of stenting that kind of securing the airway, then decide what to do, or you would go kind of as much as possible debulking?
Is there any way to see the CT again? And Dr. Kemnic, if you could tell us where the lesion was with respect to the vocal cords, was it in the subglottic space? Was it in the in the first, second, third tracheal ring space? Where was this lesion exactly?
So on our left image here, we have just gone past the cords into the subglottic space, and the beginning of the tumor is at the first tracheal ring, and it went almost all the way down to the third. We couldn't pass a flexible scope around it when we had the LMA in.
It's really, it's really difficult, because you really are thinking about the tubular anatomy of the airway. And if you think about any stent has a specific set diameter. And as you think about the airway, the trachea starts to get larger in diameter as you move proximally. And when you get into the subglottic space, it becomes even larger. So in that scenario, would you be able to, even find a stent that will fit the change in diameter to really stay where it's supposed to be? And second, the closer you get to the vocal cords, the harder it gets, right? Your stent has to be at least 2 centimeters from the vocal cords for a patient to actually tolerate it. Something that can be done, that is not done often, if you really, really think that this patient's airway needs to be, you cannot debulk completely, is, and this will become a surgical issue because this is a thyroid, ectopic thyroid tumor, is, can you do a Montgomery 2 tube? Can you do a tracheostomy? But that will become a surgical case at that time because this will not be a percutaneous approach in the setting of this being a thyroid lesion. So that's something to think about. But I would try not to stent something that's this high up because you're not going to be able to size it appropriately because the change in airway diameter, the dynamic change, as well as how close it will be to the vocal cords. Patient just won't tolerate it. So in these scenarios, you can, think about doing tracheostomies or T-tubes, but even those procedures would be difficult in this scenario and should be thought about done in a surgical manner.
I see. Thank you, Danish. And one more question for you. And what would be your follow-up on this patient? Do you routinely do like bronchoscopies through airway exam in like after 1 or 2 months, 3 months, or you just go with clinically and imaging and PFTs?
I would generally do one airway examination bronchoscopy. I don't know if there's any good. I think you can follow this patient clinically with CT scans and flow volume loops very well, and I think it would not be an easy issue. It's just been my practice that I generally end up doing a follow-up bronchoscopy, but I don't think it's necessarily indicated. So my practice would be to bring this patient back in 1 to 2 months for an airway exam. Prior to that, getting and seeing what it looks like. But I think the team had a very valid follow-up plan because the flow volume loop was very instructive in this patient, especially even the first flow volume loop that Dr. Kemnic shared, and the CT scan will also be very helpful. So you don't necessarily need to. It always has been my practice, but I think, I think there are a few ways you can follow up these patients.
Great. I think there is no wrong or right way here. So you can follow clinically. You can do some kind of surveillance bronchoscopy 1 or 2 times. Of course, that depends on a lot of things. Okay, it depends on the patient's symptoms. For example, this patient had a lot of stridor. I think if she's going to have a problem, the stridor is going to come back. Yes, that's one of the things that you can kind of clinically be careful and follow. But I think, for example, sometimes we do clinical, we follow clinically these patients, and sometimes we do the surveillance bronchoscopies at least 1 or 2 times, and make sure that the airway stays open. But I think clinical follow-up is completely reasonable. Okay, thank you, Danish. Dr. Kemnic, is there anything else you want to add, or we can kind of conclude our webinar today?
No, are there any questions in the chat that we can look at?
I don't see any questions in the chat at this point. I think we're gonna finish here. I would like to thank you for excellent presentation, and I would like to remind our attendees that this was our first Fellows Corner presentation. I encourage all pulmonary critical care fellows to submit cases. They can go to our website, Society for Advanced Bronchoscopies, and submit the case. And we're gonna have an excellent discussion. And thank you, Danish, for participation.
Of course.
Yeah, thank you everyone for joining. This was our first Fellows Corner, so we will be hosting more of these. Please fill in an application. It's on our website. We also will be having more educational webinars. Next one will be next Thursday. So we look forward to seeing you guys in the future. And thank you once again, Dr. Kemnic, for an excellent presentation. Have a good evening, everyone.
Have a good evening. Thank you.
Thank you.